Hi, good afternoon everyone. Today I'm going to speak the treatment guidelines on intra-abdominal infection. Before speaking about intra-abdominal infection, let's talk about the GI flora, gastrointestinal flora. So, what and all microfloras are there in the GI? Can anyone say? Okay, we will go from stomach. Sorry. Okay, so usually in stomach it's very less. Mostly it's oral staphylococcus and this streptococcus are present, and rarely other gram-negative bacteria are present. Now coming to the biliary tract. Biliary tract, it's a very sterile place where there is not even a single bacteria present. So it's zero. Then coming to intestine, small intestine. So in this place, you will find gram negative, rarely, very less gram positive. Gram negative in this it is Enterobacteriaceae, like E. coli, Klebsiella pneumoniae, etc. These are main. Then Enterococcus is also there. Rarely you will find anaerobics, anaerobe bacteria. Examples are bacteroids. So coming to the large intestine, here you will find majorly anaerobes. Majorly anaerobes you will find, and the count also, if you see the colony count, it gradually increases. It's very less in stomach. Biliary tract, there is no any microorganism. Intestine, it's little more, 10 to the power 6 or 10 to the power 8. So in case of large intestine, it's about 10 to the power 10 kind of colony count. CFUs will be present. This is how the GI flora. So mainly those which are present are E. coli, Klebsiella pneumoniae, and bacteroids. These are the main important microflora which can cause intra-abdominal infection. So now coming to the classification. So intra-abdominal infections, it can be classified. See, you see biliary tract. So gallbladder is present in the biliary tract system, where the bile flow from the liver to the intestine is present. That is very sterile. So the infection or the inflammation present in the biliary tract, it is gallbladder inflammation, that is cholecystitis, and inflammation of the biliary tract, it is called cholangitis. These are two intra-abdominal infection. Then comes peritonitis. So what is peritonitis?
Inflammation of peritoneum.
Yeah, inflammation of the peritoneal cavity and retroperitoneal space. So there is this anterior and posterior cavity along with the peritoneal cavity. So those. So in peritonitis, there is another three classification, that is primary, secondary, and tertiary. Where primary, it is due to direct inflammation of the direct infection. So there is no other root causes like any other infections. So in which case and all, so in nephrotic syndrome, we can see direct the primary peritonitis, and in case of liver injuries like ascites will be there. So in that condition also, there is chance of direct primary peritonitis. So it is also called as spontaneous bacterial peritonitis. There is one word, I am not able to recollect that. So that is one thing. Secondary peritonitis is where there is an injury. For example, the abdominal region is there will be an injury. So in case of trauma, one condition trauma, there will be a secondary peritonitis, some major accident or something towards that position, the abdominal region. Another thing is appendicitis, the inflammation in the appendix. that can the GI, there will be a layer between the intestine and the cavity. So because of the bacterial growth, the bacteria will transform, will get into the peritoneal region. That is how the secondary peritonitis is caused. Another one is diverticulitis. So appendicitis, then diverticulitis. So diverticulitis is something, there is a cavity like structures in the intestine. There will be a hole, if it is a intestine, so there will be this kind of structure. If you see anatomically, you will see that place is called diverticulus. Yeah, so the inflammation in this region is called diverticulitis. So because of this, again it can get into the peritoneal region, and again the inflammation in the peritoneal region is caused. These are some major things. The tertiary peritonitis is something where the patient has secondary peritonitis that will transform or it go into septic shock or sepsis, or the secondary peritonitis is gone, but then it again reoccur. When it reoccur, then it is called tertiary peritonitis. These are the different classifications of intra-abdominal infection. Now I'll speak about cholecystitis and cholangitis. So I'll roughly draw a gallbladder. So if this is gallbladder, think it is gallbladder, I don't know if it looks. So major cause of cholecystitis is, guess?
Gallstone.
Yeah, gallstone. So what happens is it blocks the gallbladder. So what happens? There will be no biliary flow. The mechanism or the pathogenesis is bile is there, no? It is bacteriostatic in nature. When there is no flow, it causes the place is very susceptible for the bacterial growth. That is how the cholecystitis, there is a inflammation in the gallbladder, and then cholangitis is a biliary tract. This gallstone can move out of this and block this. It will be small, to be frank. That is there is a term, cholelithiasis. Yeah, so something. Yeah. So that will be there. In this case also, there will be no flow of the bile. When there is no flow of the bile, this place are very possible for the bacterial growth, because it is not sterile now. There is no bile there. That is how the inflammation of cholangitis, biliary tract occurs. This is the pathogenesis of the cholecystitis and cholangitis. Now I'll go to the clinical manifestation. So in the major, this is cholecystitis and cholangitis is very similar. In cholangitis, one thing about the infection is the major thing about infection. What is the clinical presentation of fever? Fever, yeah, I said it. Okay, fever. Another thing is, see, it is related to bile. So there is a block of bile. So it can cause. One thing is there, yeah, abdominal plane. That is a very specific. Right upper quadrant region abdominal pain. And another thing is jaundice. That is it's called Charcot's triad. So jaundice, again, the differentiation between cholecystitis and cholangitis. In case of cholangitis, the jaundice is more. That is greater than bilirubin greater than 2 mg per dl. It's up to 6 mg per, greater than 6 mg per dl. Greater than 2 mg per dl. In case of cholecystitis, it can be, it's not very significant, jaundice, but then it is very less increase in the bile. So these are the clinical manifestation. So in there's other clinical manifestations are nausea and vomiting. So these are the main presentations of cholecystitis and cholangitis. Now coming to the diagnosis. Mainly diagnosis is the ultrasonography or ultrasound scanning, where you will find the gallstone or the this stone in the biliary tract system. So these are the main thing. Now coming to the treatment. First thing what we do in intra-abdominal infection is source control. There will be a pus formation, abscess formation, or the gallstone, for example, it is there. The control of that is required. So in case of cholecystitis, we do removal of gallstone, ERCP, and cholecystectomy. These are the what to say, source control which are done in case of cholecystitis and cholangitis. So after that, what we have to do is start the empirical therapy. So yeah, first before that, what we have to make sure is they have to send the blood culture before starting any antibiotics. That is the major thing which we have to see. Okay, now coming to the treatment, antibiotics. So it can be differentiated, like given mild to moderate, based on the severity. One is mild to moderate. Another one is severe, very severe. Okay, so in this, again, I think space is not enough. There are two types of option. That is, one is single agent, and the one is combination therapy. So what we have to notice here is, or how we have to select a regimen is based on the bacteria which can cause infection. So majorly it is E. coli. So we have to cover gram negative bacteria. This gram positive are very rare because it is not its it's not a microflora of the GI in the stomach or intestine region. So another thing is bacteroids. This also we have to. So we have to cover anaerobes, we have to cover gram negative. These are the things which we have to see. So that is in mild to moderate. So in severe conditions, we have to cover Pseudomonas aeruginosa also. These are very rare. Genosa, and another hospital acquired infection, again the intra-abdominal infection, which is hospital acquired. Then we have to treat based on this regimen, this treatment guideline. So the treatment guideline is single agents which the drugs which covers anaerobes as well. In case of combination, why we do combination is because one drug will cover anaerobe, one the drug which will not cover anaerobes. So how the drug which cover gram negative bacteria and drug which cover anaerobes, that is how the two combination is done. So in case of single agents, we use our ertapenem. What is the duration and the dose? Okay, it's 1 gram OD. It is highly protein bound, so OD is sufficient. The other is moxifloxacin. Again, moxifloxacin is the only fluoroquinolone which has activity against anaerobe as well. Okay, so the dose is 400 mg, again OD. Remember that. Then tigecycline and cefoxitin. These are the 4 drugs which are used as a single agent in mild to moderate severity intra-abdominal infection. This is cholecystitis and cholangitis. So tigecycline, 100 mg loading dose, then 50 mg maintenance dose. Again, it's BID, twice a day. Another thing is cefoxitin. So again, this is 2 grams IV every 6 hours. It's again time dependent. Okay, these are the monotherapies which are used, and then coming to the combination. So for intra-abdominal infection, which combination we have seen in this hospital? Metronidazole. Okay. What is the dose of metronidazole? 400 is tablet, I guess, right? 500 mg is IV. Okay. 500 mg IV TID. So metronidazole covers anaerobes, bacteroid, fragilis. It covers anaerobes. Plus, this is the sole drug. Along with this, we give other combinations. So, which you have seen here. Okay, ceftriaxone. Everyone knows the drug duration and drug dose. 1 gram BD. Okay, it can be 1 gram up to 2 grams. So it can be given every 24 hours as well. Another one is ciprofloxacin. You have seen this commonly, I guess. So again, this is 400 mg BID. Others are again the same class we have used. We can use levofloxacin. This is 750 mg OD. Other which can be used are cefazolin 1 to 2 grams TID and cefotaxime 1 to 2 gram QID every 6 hours or TID. These are the combination or the treatment regimen which are there for mild to moderately severe infection. So in case of severe is like very severe cases or complicated cholecystitis or hospital acquired cholecystitis, we start here again single therapy. We use piperacillin and tazobactam. It will cover Pseudomonas aeruginosa as well. So I said you that time also. The complicated, I mean severe things we will cover Pseudomonas aeruginosa as well. This can be said by anyone. 4.5 grams Q6H. This is one drug. Other which can be used are carbapenem drugs, meropenem, ertapenem. We use it. It doesn't have coverance. This Pseudomonas aeruginosa. Imipenem, cilastatin. It comes as a combination every time. So and doripenem. So meropenem dose 500 mg. It is actually sorry. It is 1 gram TID. Doripenem it is 500 mg TID. Imipenem it is 500 mg every 6 hours or 1 gram TID. Okay. This is the single therapy or the single drug which can be used for severe intra-abdominal infection. In case of combination thing, again it is metronidazole 500 mg TID. So along with this, we can use cefepime. Which generation is this? Second generation, fourth generation. So it has coherence pseudomonas aeruginosa. That is the logic between the change in the regimen. So cefepime is 1 to 2 grams IV TID. Then again, ciprofloxacin and levofloxacin is the drug which comes in both categories because it has coherence towards the Pseudomonas aeruginosa. So same thing applies here. Another drug is the new one, new cephalosporin, that is ceftazidime plus avibactam. Dose is 2.5 grams IV TID. So these are the two drugs in combination with metronidazole can be given in the severe acute cholecystitis or hospital acquired cholecystitis. So yeah, these are the thing. And one more thing which we have to focus is the local antibiograms. Local resistant pattern of the hospital is we have to look into it. So we have seen majorly, I've noticed the resistant towards fluoroquinolones are increasing here. So another thing is we can give, before they used to give aminoglycoside also. It has a occurrence like coverage towards the all the bacteria which I said about. So but the thing is it has a more majorly nephrotoxic drug it is, so we don't prefer it in the first phase. Then amoxicillin or ampicillin, the resistance has increased, so we don't use it anymore. So these are the drugs which are used in intra-abdominal infection right now. Okay. Duration, yeah. Thank you. So the duration is after the source control, the drug has to go for 4 to 7 days. 4 is enough. 4 to 7 days is the cutoff. 4 days is enough. So the research says that there's an article or the research which compared the duration, the 10 days duration of the drug versus the 4 days duration. So there was no any difference between the regimen. Moreover, what happens is any recurrence of the bacterial growth has happened, it is lately seen in the 10 days criteria. So that diagnosis will be delayed in that case. That is one thing. So 4 to 7 days is the preferred duration. Okay. Thank you.